So for our final lecture, we're going to be talking about the lower extremity. Looking at the lower extremity, we see that we first begin with the hip joint. This is one of the most important joints of the body, and we see that the hip provides strength to carry the weight of the body in an erect position, but it also allows movement as well. And so not only does it have an enormous amount of strength, but it also has the freedom of movement as well. It is a synovial ball and socket joint. What we mean by ball and socket is that you have a socket and you have something that fits inside of it. And so, as we can see here, this is the acetabulum, the socket, and the ball is the femoral head. So the acetabulum is a cup-like cavity which is formed by three bones of the pelvis, the ilium, ischium, and the pubis. And so all three bones of the pelvis actually make up the acetabulum. Very interesting in this respect. So that brings us to the femur. The femur is the longest, heaviest, and strongest bone in the body. So definitely know this. What is the longest and strongest bone in the body? The proximal end of the femur has a head, neck, and two large processes. We have the greater and lesser trochanters. The greater trochanter provides an attachment for several muscles of the gluteal region, whereas the lesser trochanter provides an insertion to the tendon of the psoas major muscle. Between the trochanters is the intertrochanteric crest. The femoral head is covered entirely by articular cartilage, with the exception of a small centrally located pit. The femoral neck is angled 120 degrees to provide an increased freedom of movement within the hip joint. You definitely know the angulation that is supposed to be caused by the femoral neck. And we see this kind of embodied as we have the head and the neck coming down. And so that's what really allows the hip to function properly. We also have a mixture of labrum and ligaments. The femoral head is held to the acetabulum by several major ligaments, such as the acetabular labrum, the transverse acetabular ligament, the iliofemoral ligament, which basically amounts to the strongest ligament of the body, spans from the anterior and inferior iliac spine, and the rim of the acetabulum to insert on the intertrochanteric line of the femur. We also have the pubofemoral ligament and the ligamentum teres. So it's essential that we have the femoral head held into place. Without these ligaments to hold it in, there would be no way that walking would be sustainable, as the amount of pressure that would be applied to the acetabulum would cause the femur to just kind of pop out. And so it's essential that these ligaments function. Any decrease in functionality of these ligaments will allow displacements or dislocations to actually occur. So the articular capsule of the hip joint. The fibrous capsule of the hip is strong and dense. It forms a sleeve that encloses the hip joint and most of the neck of the femur. The synovial capsule of the hip joint lines the internal surface of the fibrous capsule. It protrudes inferior to the fibrous capsule on the posterior aspect and forms the obturator externus bursa, which protects the tendon of the obturator externus muscle. And so here we have the acetabulum, which is the cup-like depression. And as we can see, we have the ischium forming this portion, the pubis forming this portion, and the ilium forming the upper portion. Here we have an actual view of the hip joint. as we can see, we have the acetabulum, we have the femoral head, we also have the acetabular fossa. This is this. Fovea capitis. And that is it for this image. Here we can get an idea of how everything is kind of held in place. However, we're not going to focus too much on this other than just bony anatomy. Here we have femoral head, femoral neck, greater trochanter, and lesser trochanter. Okay, here we see with the patient laying supine, we have the pubis coming out anterior, we have the ischium bilaterally, then we have femoral head, femoral neck, and then we have greater trochanter. Here we have lesser trochanter and just the shaft of the femur. Okay, here is a view of the femur in its entirety. Notice we have femoral head, femoral neck, greater trochanter, lesser trochanter, body or shaft. Then that brings us down to these prominences here, which are the epicondyles. And then we have the patellar surface. Additionally, looking at it from a posterior view, we have the greater trochanter here, lesser trochanter, body. We have the medial epicondyle, lateral epicondyle, medial condyle, lateral condyle, intercondylar notch, which means that it's in between the condyles. Once again, though, everything looks different when you're looking at it in the terms of CT. And so here we have a volume rendering of the pelvis as well as the hips. So notice we're not going to focus on the pelvis because we've already covered that. So as you can see, we have the acetabulum bilaterally, we have the femoral head, we have femoral neck, greater trochanter, lesser trochanter, and then we have the body of the femur. Additionally, we have the superior ramon, inferior ramon, symphysis pubis, here is the femur in volume rendering. Notice how we are actually looking at this. This indicates to us that we are basically looking at it from a PA position with the patient's front being away from us. So here we have the acetabulum once again. We don't really see the femoral head, but we do see the femoral neck. The greater trochanter, lesser trochanter, body. Then we have lateral condyle, medial condyle, medial epicondyle, lateral epicondyle, intercondylar notch, inferior rami, superior rami.
We have the femoral head, the shaft of the femur as it comes down. Notice we have the gluteus medius muscle and the gluteus minimus muscle. The bladder is seen as well. And we have the vastus lateralis muscle, the vastus intermedius muscle, we have the adductor brevis muscle, the adductor longus muscle, the adductor magnus muscle, the sartorius muscle, and the gracilis muscle.
So, the muscles of the gluteal compartment. First is the gluteus maximus muscle, which is the largest and most superficial of the gluteal muscle group. It's very powerful, and this is one of those that you typically hear referred to a lot. And it acts as an extensor of the hip and is responsible for maintaining the erect position. So simply know this. The gluteus medius muscle and the gluteus minimus muscle act to abduct and medially rotate the thigh. So once again, know the function. The piriformis muscle, actions include lateral rotation and abduction of the thigh. The obturator internus muscle, which functions similar to the piriformis muscle. The obturator externus muscle acts to laterally rotate the thigh. The quadratus femoris muscle functions to laterally rotate the thigh. And so the obturator externus muscle and the quadratus femoris muscle are kind of working together. So the muscles of the anterior thigh compartment. The psoas major muscle and the iliacus muscle act conjointly to flex the thigh at the hip and stabilize the hip joint. The sartorius muscle is the longest muscle in the body. It acts to flex and abduct and laterally rotate the thigh. Another thing to keep in mind and put a star by, the sartorius muscle being the longest muscle in the body. The quadriceps femoris muscle is the biggest muscle in the body. It acts to extend the leg at the knee joint and through the actions of the rectus femoris. In this image, we can kind of understand the relationship with the gluteus maximus and the gluteus medius. If we break the name down, the maximus and the medius, see, medius means middle, while maximus means superior. And so minimus means inferior. So if we tie all of these things together, we can see that maximus is superior to the medius in this respect. We don't see the minimus here, but we can, based on the name, that it is actually inferior to the gluteus medius. Here we can kind of see this. I know the image down here at the bottom is kind of messed up, but here is gluteus minimus. Here's the gluteus medius. And here is gluteus maximus. So we'll draw it on the other side as well. Here's the minimus. Here's the medius. Here's the maximus. Here we have the sartorius muscle. And then once again we have the gluteus medius, or minimus. Medius. And the maximus. Don't worry about this down here at the bottom. I think this is kind of skewed. Here we have the minimus, medius, and maximus. Also we have the rectus abdominis muscle here. Here in this image, we see that we have several muscles groups, but the only ones that we're going to focus on is the sartorius here and the gluteus maximus here. So as we venture down the femur, this kind of demonstrates to you where everything is located. Notice we have the sciatic nerve in the posterior portion. We have the sartorius muscle, and we have the femoral vein. So here we have a similar section of anatomy with the sartorius muscle being right above the femoral artery. Deep to the femoral artery is the deep femoral artery. Here we can see the outline of something running here, and that is the sciatic nerve. And then we have the gluteus maximus muscle. Here we have the femoral artery coursing down. As we're getting close to the knee, the femoral artery then becomes the popliteal artery. Notice right beside of it with slight degree of contrast enhancement is the popliteal vein. That brings us to the muscles of the posterior thigh compartment. We've all heard of these, the hamstrings. And this includes the semitendinous, semimembranosus, and the biceps femoris muscles all combined together, which is collectively known as the hamstrings. And basically what you need to know about the hamstrings is this, that they are a large mass of muscles that can be palpated on the posterior aspect of the thigh and are involved with extension of the hip, flexion of the knee, and rotation of the flexed knee. And so all of these work together to perform some very vital functions of the leg. So that brings us to the distal femur. As we can see, the distal femur broadens into two projections, the medial and lateral condyles. The lateral femoral condyle is wider in front than in back, whereas the medial femoral condyle remains more consistent in width. On the side of each condyle is a raised edge called the medial and lateral epicondyles, which are there for the attachment of ligaments and muscles. On the posterior surface of the distal femur is a triangular area called the popliteal surface. So the tibia. The tibia is also called the shin bone. It has a widened proximal end and has two cartilaginous projections, which are the medial and lateral condyles. The tibial plateau is a flattened surface that enables articulation with the femoral condyles. Also, we have the intercondylar eminence, which separates the tibial condyles. There's two peaks to that, the medial and lateral intercondylar tubercles. The shaft of the tibia is triangular with a large anterior edge or crest that contains a bony projection called the tibial tuberosity, or the attachment of the patellar ligament. The tibial tuberosity has a tendency to become displaced at a young age, and you'll see widening of this area, which is called Osgood-Slaughter's disease. It's due to activity during the teenage years or in the youth. The distal tibia has a flattened articular end with a medial extension that forms the medial malleolus. The fibula, on the other hand, is a relatively thin, long bone that has expanded proximal and distal ends. The proximal end is the head of the fibula and a sharp superior apex, and medially has an articular surface for articulation with the lateral condyle of the tibia. The distal end forms the lateral malleolus. So that brings us to the patella. The patella is the largest sesamoid bone in the body and is embedded within the quadriceps tendon. It is a subcutaneous flat triangular bone with a broad base facing proximally and a pointed apex facing distally. The base of the patella has roughened areas for the attachment of the rectus femoris and vastus intermedius muscles, whereas the roughened medial and lateral borders receive attachment for the vastus medialis and lateralis muscles. The patella protects the anterior joint surface of the knee and functions to increase the leverage of the quadriceps extensor system. So that brings us to the knee joint. The knee is the largest and one of the most complex joints of the body, and we can fully attest to that. The bones that contribute to the knee joint are the femur, tibia, and the patella. A supporting network of menisci, ligaments, tendons, and muscles function together in order to meet the demands made of the knee. So basically, as we can see, the knee is very much in charge of supporting the lower body as well as providing flexion and extension, and basically to allow it to operate to a high degree for a long sustained period of time. So the menisci and ligaments of the knee. There are C-shaped menisci composed of fibrous connective tissues which cushion the articulation between the femoral condyles and the tibial plateaus. So what you have to know about menisci is that they function as a cushion between the femoral condyles and the tibial plateau. The medial meniscus is crescent shaped with the posterior horn being wider than the anterior horn. The lateral meniscus almost forms a closed ring with anterior and posterior horns of approximately the same width. The two menisci are connected anteriorly by the transverse ligament. So here we can see a diagram of the knee. So as we can see, we have the distal femur, then we have medial epicondyle, lateral epicondyle, lateral condyle, medial condyle. We have the tibial spine here. We have the tibial plateau, tibial tuberosity somewhere around this area, the fibula, also the patella. As you can see, the pointed end always faces inferior or distal. Here is a volume rendering of basically the drawing. You can see that it's a little more difficult to kind of see. We have the medial epicondyle, lateral epicondyle somewhere in here, Notice this is kind of turned in an oblique fashion on a straight up AP, so that kind of skews this a little bit. We have the lateral condyle, the medial condyle, tibial spine with the intercondylar eminence here, tibial plateau, tibial tuberosity, and the fibula. So here we have an axial image of the knee joint. As you can see, it becomes a little more difficult to actually see where we are. As we can see, we have the patellar surface of the anterior portion of the knee. We have the patella here. We have this joint that is created, which is the patellofemoral joint. We have the lateral condyle, which is very difficult to see, and the medial condyle. But here we have the intercondylar fossa. Notice how it is a depression in between the condyles. And so we would assume that this area here is the medial condyle, this is the lateral condyle, here is the intercondylar eminence. However, I often find that the knee is much more appreciated looking at it in terms of the coronal view, so you can see all of the anatomy. So here we have the femur again, we have the acetabulum, we have the hip joint here, femoral head, femoral neck, greater trochanter. We don't see the lesser trochanter because it is in profile. The body of the femur, we get down to the medial epicondyle, the lateral epicondyle, lateral condyle, medial condyle. And we can kind of see the tibial spine with the intercondylar eminence there. So here is a diagram of simply the tibia and the fibula. As we can see, we have the tibia, the tibial plateau, the lateral condyle, the medial condyle, the intercondylar eminence, tibial tuberosity, body of the tibia. We have a line running down straight, and you can feel it being the prominent portion as you're running. If you run your hand over your tibia, that is the anterior crest. Then we get down to the distal portion, and we have the medial malleolus, forming a portion of the ankle joint. Referring back to the fibula, we have head of the fibula. We have the body. Then we have the lateral malleolus here formed on the fibula. It's important to note that the fibula is not really a weight-bearing portion of the bone, but it does help to keep the ankle in check in the lateral portion. And so some would argue that the fibula is non-essential, but it does serve a great purpose in providing attachment points for ligaments and tendons, as well as keeping the ankle in place. So here we are looking at the proximal portion of the tibia. Really not seeing the fibula yet, but as you can see, it's kind of hard to see, but this is all basically the tibial plateau, and what we're focusing on is the lateral tibial plateau versus the medial tibial plateau. Other than that, it's very hard to discern. We're not going to worry about the meniscus because it's very difficult to really kind of focus in on this image. Here we have the fibula and the tibia. Notice we also have the popliteal artery as it is going in the posterior portion. The popliteal surface of the tibia and is highlighted by contrast. Looking at the patella, we have the base being the kind of flat portion on the proximal portion, and the apex being the kind of pointed distal portion. So here we see the patellofemoral joint right here, and we have intercondylar notch, and we have medial condyle, lateral condyle. It's important to note that any narrowing of this space here can cause great abnormalities with the knees and can cause severe pain. So we see that a lot of times in older age where the patellofemoral joint becomes narrow, and because of this, patients report having difficulty moving their knee, stiffness, things like that. So this image is almost identical to what we've seen. Here is the patella coming in. We have the patellar surface of the femur. We have intercondylar notch. We have lateral condyle, or should I say medial condyle and the lateral condyle. We have the popliteal artery. We can look at the ligaments here. We have the anterior cruciate ligament, or the ACL. We have the posterior cruciate ligament here, which is the PCL. You'll hear of the ACL quite common in athletes to tear. Very important, can cause quite a bit of abnormalities of the knee if damaged. Venturing down into the tibia and fibula now, we have the tibial tuberosity. Notice how it kind of juts out, creating a prominence here. We have the posterior tibial artery now that we've transformed from the popliteal to the tibial artery. We have also the great saphenous vein, fibula, okay, here once again we have we're about mid shaft, so we have the body of the tibia, body of fibula. We have posterior tibial artery. We have the great saphenous vein. Notice here we have the Achilles tendon, which is this area here. Venturing down even farther, we have the Achilles tendon looking more prominent in the posterior portion. Notice we have the posterior tibial veins here and posterior tibial arteries. The veins are going to look much more dilated than the arteries will. Here's a sagittal view, which kind of allows you to see the patellofemoral joint very well in profile. Notice we can see some degree of spacing here. So we have the distal femur. We have what looks to be, or where we're at is the intercondylar notch. Notice we have the tibial tuberosity, tibial plateau, and we're getting down into the foot. We have the sinus tarsi, calcaneus.
We have the femur, and this is medial condyle and the lateral condyle. Here's the intercondylar eminence with the tibia plateau We do have the medial collateral ligament, the lateral collateral ligament, the PCL, and we do not see the ACL. Here we have the patella, femur, and the tibia. Notice we have the ACL, the PCL, the posterior menisco-femoral ligament, the gastronymicus, okay, so looking at this portion of the posterior, or the distal femur, you see that we have ACL and the PCL, the medial collateral ligament, and lateral collateral ligament. At the calf, notice that we have fibula, and here we have the tibia, although we're not really seeing much of it in profile. Notice that we have the peroneus longus muscle, peroneus brevis muscle, we have posterior tibial artery, the Achilles tendon, and notice we have the sartorius muscle still coming in. Here we have the gastronymicus muscle, the medial head.
So that brings us to the ligaments. The ligaments of the knee are divided into external and internal ligaments. The external ligaments are arranged around the knee and serve to strengthen and support the joint capsule. The internal ligaments are found within the joint capsule and serve to provide stability to the tibia and the femur. So each of these ligaments are very important. The collateral ligaments provide support for the knee by reinforcing the joint capsule on the medial and lateral sides. The medial collateral ligament is a flat and triangular ligament that originates from the medial femoral epicondyle. The lateral collateral ligament is more of a rounded cord arising from the lateral femoral epicondyle and attaching to the head of the fibula. The patellar ligament is the strong, thick band representing a continuation of the quadriceps tendon that extends from the patella to the tibial tuberosity. So internal ligaments, they are in charge of providing anterior and posterior stability to the knee. These are the ACL, which is the anterior cruciate ligament, which helps prevent hyperextension and anterior displacement of the tibia. And so this is what you're going to see, hyperextension and anterior displacement solely of the tibia. And so anyone who has an ACL injury can attest that it feels like your tibia is jutting forward from the femur. The posterior cruciate ligament is stronger than the ACL, and it's used to prevent hyperflexion and posterior displacement of the tibia. And so the ACL keeps it from going forward, PCL keeps it from going backwards, so it keeps it in a stationary position. It can be hypothesized that when you have one abnormality, such as an ACL tear, It can cause wear and tear on the posterior cruciate ligament as well, and therefore wear it out, simply because of the fact that you're creating a greater amount of strain for this ligament to keep it in place. So the bursa. There are more than 10 bursa located around the knee joint owing to the number of muscles associated with the knee. Bursa are difficult to see on cross-sectional images unless they are abnormal. So that brings us to the gastrocnemius muscle, which is a prominent flexor of the foot, and it's responsible for giving the calf its shape on the back of the leg. It has two heads which basically form the lower boundaries of the popliteal fossa. The fibers run distally where they join the tendon of the soleus muscle to form the Achilles tendon that inserts on the calcaneal tuberosity. And so the Achilles tendon is a mixture of the gastrocnemius muscle and the tendon of the soleus muscle. So that brings us to the ankle and the foot. The bony anatomy of the ankle and the foot includes the tarsus, metatarsus, and the phalanges. So if we initially begin at the ankle joint and work our way down, we'll see that the first bone that we would encounter is the talus. It is the second largest tarsal bone and responsible with the calcaneus for transmitting the entire weight of the body to the foot. So it's very important that this bone remains intact. It consists of a body, head, and neck. The calcaneus, on the other hand, is the largest tarsal bone, and it lies directly beneath the talus. It has an elongated cuboid shape with posterior surface compromising the prominence of the heel. The articulation between the talus and the calcaneus is the subtalar joint. In addition to the talus and calcaneus, the cuboid and navicular and three cuneiform bones comprise the remaining 5 tarsal bones of the foot. So we see that the metatarsals are long, slender bones. There's 5 metatarsals in each foot. Each bone has a distal head, proximal base, and a body or shaft in between. The phalanges then are what we refer to as toe. Each foot has 14 phalanges, 3 phalanges for each toe except the great toe, which has just 2. And so we see that the foot is comprised of several bones that all have to work together and function together to actually allow the foot to support the weight of the body. So the joints of the foot are pretty numerous in terms of how many there are. But we see that there are a few key joints. The first is the talocrucial joint, and it makes up what we call as the ankle joint. Tarsal-metatarsal joints are the joints between the bases of all 5 metatarsals and the interior 4 tarsal bones. The intermetatarsal joints are the articulations between the bases of the lateral 4 metatarsals. Metatarsophalangeal joints are the articulations between the heads of the metatarsals and the phalanges. Interphalangeal joint, as the name implies, is the articulations between the phalanges. So that brings us to the arch of the foot, an often overlooked portion. The bones of the foot are arranged in a transverse and longitudinal arch that provide the flexibility and the resiliency of the foot to support the weight of the body, absorb shocks, and provide spring and lift during activity. The longitudinal arch provides a firm base for support of the body in the upright position. And now the transverse arch is the major weight-bearing arch of the foot and helps to distribute the weight of the body over the entire base of the foot. And so what the arch helps to do is provide an effective foundation so that the rest of the body can be balanced. That's why you see people who don't have an arch or are what we call flat-footed have a tendency to have higher incidences of pain in their feet because the weight of the body is being supported and it's not being supported very effectively. And so the arch is often overlooked but very important. So the only tendon we're going to be talking about here is the Achilles tendon, which is the largest and most powerful tendon in the body. You injure your Achilles tendon, and it's very painful, and it really affects the range of motion that you have. So here we have a skin going almost into the foot. As we can see here, we're entering the ankle joint. So we see the talocrucial joint here with the medial malleolus and the lateral malleolus. The talus is in the middle, and so this is all the talocrucial joint. In terms of looking at the foot, we have the talus, calcaneus, which is lying directly below. Slightly anterior to the talus is the navicular. And slightly anterior to the navicular are the three cuneiforms. We have the medial, lateral, and intermediate cuneiforms. And then we have the cuboid. And so an easy way to remember this is milk with a C, not K. And so that will take you from medial to lateral on the most distal row of the tarsal bones. After we leave the tarsal bones, we have the metatarsals, which are pretty lengthy, and you see that there are 5 of those, and then the metatarsals give way into the phalanges, and this creates the metatarsal phalangeal joint here, here, and here. And then we can see that the great toe has 2 phalanges. All the rest of the toes have 3. And so this is proximal, middle, distal, and this is just proximal and distal. Inside phalanges, we have the interphalangeal joints. So this gives you an idea of kind of the arch of the foot. As you can see, you have this kind of shape, which helps to support the weight of the body. So if we're looking at it from a lateral view, we're seeing that we have the middle cuneiform, intermediate cuneiform, navicular, talus, calcaneus, first, second, third metatarsals, proximal and distal phalanges, and that's pretty much all that we can see from this image. Here is a lateral medial view, and we see that we have the cuboid, lateral cuneiform, intermediate cuneiform, navicular, talus, calcaneus, sinus tarsi, 5th, 4th, 3rd, 2nd, and 1st metatarsals, and we can see that we have the proximal, middle, distal phalanges all the way. Which, curiously enough, this diagram is drawn wrong for the foot. As you can see, this would be first, and we have proximal, middle, distal, which is not the case. So here's a diagram that will help us kind of relate where everything is. Notice we have the Achilles tendon coming in, attaching to the calcaneus. So you're going to see the Achilles tendon even as you're going through the calcaneus. Here we have the tibia. Here we have the talus, calcaneus. We have the navicular, and then this brings us to the intermediate. And then this is second metatarsal bone. Additionally, we have the subtalar joint, sinus tarsi, which allows for the interosseous talocalcaneal ligament. We have the talocrucial joint. We have the tarsometatarsal joint, proximal, phalanx, which articulates with the second metatarsal to form the metatarsal phalangeal joint. So, looking at it in terms of CT, here we have the talocrucial joint, talus, tibia. Here we have the subtalar joint, sinus tarsi, calcaneus, and then here we have the cuboid. Here we have basically the mortise joint, the talocrucial joint. Here we have the fibula, and more importantly, the lateral malleolus. Here we have the tibia, medial malleolus, talus, calcaneus. I believe we've already saw this with lateral malleolus, medial malleolus, and then the talus forming the talocrucial joint here. Okay. Here we have a scan through somewhat of the foot. It's kind of not going through a straight angle, but we're going through kind of at an oblique. And so because of this, we have calcaneus, talus, and talus, and talus here. We have the navicular. We have the medial cuneiform, intermediate cuneiform, lateral cuneiform, and then somewhere over here is going to be the cuboid. We have the first metatarsal, second metatarsal, sinus tarsi here. Okay, so we have the navicular, lateral cuneiform, intermediate cuneiform, medial cuneiform, cuboid, calcaneus, second metatarsal, or first metatarsal, second metatarsal, third metatarsal. Here we have the cuboid, lateral cuneiform, intermediate cuneiform, medial cuneiform, calcaneus, third metatarsal, second metatarsal, first metatarsal, metatarsal phalangeal joint, proximal phalanx of first metatarsal. Here is the tarsometatarsal joint. Once again, here is the talocrucial joint. We have lateral malleolus, medial malleolus, talocrucial joint, subtalar joint, calcaneus, talus. Here's a sagittal view. As we can see, based on this image, we're going through what looks to be the third metatarsal. And so, based on that, we can say that we are going through the cuboid, calcaneus, talus, tibia, fibula, lateral cuneiform, and then we have third metatarsal. Then we have the proximal phalanx of the third metatarsal with metatarsal phalangeal joint and a tarsal metatarsal joint here. Here we're going through the second metatarsal, and we have calcaneus, talus, navicular, cuboid, And so that brings us to the medial cuneiform and the intermediate or lateral cuneiform. This is kind of debatable here whether this is lateral or intermediate, but either way we have metatarsal phalangeal joint, tarsal metatarsal joint, proximal phalanx of the second metatarsal, sinus tarsi, subtalar joint, talocrucial joint, intertarsal.
Okay, on this image we have the distal tibia forming the tibiotalar joint. Here's the talus, and this is the calcaneus. Here we have the navicular. And this joint here is the talocalcaneonavicular joint. Additionally, we have the Achilles tendon coming down here, which we don't see all of the calcaneus in profile, so that we don't really catch the Achilles tendon coming in all the way, but we do see the start of it coming in. Here we see the lateral malleolus, which is formed by the fibula, and the medial malleolus, which is formed by the tibia. We see the talus coming into the field of view, and we see the Achilles tendon lying posterior, going to attach to the calcaneus. In this ankle joint, we see that we have the medial malleolus. We have the tibiotalar joint, the talus, calcaneus here, we have the mortise joint intact, tendon attaching to the calcaneus at the posterior segment, with the calcaneus lying just anterior. We also see the medial cuneiform, the intermediate cuneiform, and the lateral cuneiform, with the navicular lying somewhere in this area, and the cuboid just coming into the field of view as well. We do see that we have the quadratus plantae muscle, here we have the calcaneus. We're looking at the sole of the foot, or the plantar surface. We have the calcaneus, the fifth metatarsal, and the base of the fifth metatarsal coming in. And we have several muscle groups here. We have the flexor digitorum brevis muscle, quadratus plantae muscle, the flexor digitorum longus tendon, the flexor hallucis longus tendon, and the abductor digiti minimi muscle. We're not going to worry too much about those because
So basically, I'm going to have just kind of a little review over arteries and vessels. Basically, as we're coming down through the aorta, we have celiac access, which is right around here, and then we have superior mesenteric or SMA. Then we have the IMA somewhere, probably around here. We have the bifurcation of the aorta, and then the aorta, at this bifurcation, it goes into left and right common iliac arteries, and then these common iliac arteries bifurcate again to form the left and right internal and external iliac arteries. As we saw, the external artery is very large and continues down the leg to become the femoral artery, whereas the internal artery, just as the name implies, kind of situates itself in the pelvis and supplies the pelvic area with blood. So as we continue down, the external becomes the femoral artery, and you'll notice the femoral artery on your scans because it's very large and it's going to always appear white when you're injecting contrast. Additionally, we have the acetabulum, femoral head, femoral neck, greater trochanter, superior pubic rami, and additionally, notice that the femoral vein is situated right next to the femoral artery. Here we have the femoral artery, and notice the femoral vein has contrast enhancement in it as well. So we'll return back to the heart. So as we see, we have the external iliac artery comes down, and then it bifurcates to a certain degree here, but continues down as the femoral artery till around the knee, and then it becomes the popliteal artery. As it becomes the popliteal artery, and then continues down to supply the lower portion of the leg, which we can really demonstrate over here. It becomes the tibial and the fibular artery. And so as we can see, the tibial artery is very large, while the fibular kind of remains very small. And we can see this kind of bore out here to supply the lower portion of the leg. Here we can really see this demonstrated on CT. We have common iliacs, or external iliac, and then becoming the femoral artery. And as we come down around this area, it would become the popliteal artery. Also notice we have lateral circumflex femoral artery and the medial circumflex artery. Then as we reach tibia and the fibula, we become the tibial and the fibular artery. Here you can see the tibial artery, and then to slide them out, the fibular artery as well. And that concludes our lecture. If you have any questions, just let me know. Send me an email,